Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Welcome everyone. We are here again in our EPSA weekly webinar meeting. And tonight we are a combined EPSA WOFAPS meeting with the presence of the president of WOFAPS, as well as one of the speakers is the Secretary General of WOFAPS. And I am the Middle East representative. So we have three WOFAPS sharing in this meeting. So it's an EPSA WOFAPS meeting on the 24th of June, 2020. Tonight, the topic of the meeting is the neuroblastoma updates, and we do have three eminent speakers from Tanta University, Cairo. We do have Professor Dr. Nihal Al-Mashad, a professor of pediatric oncology, and from Frankfurt, Germany, Professor Dr. Udo Roller, who is the Secretary General and the Treasurer of WOFAPS. He is a professor and the Surgeon-in-Chief of the Department of Pediatric Surgery and Pediatric Urology at Goethe University, Frankfurt am Main in Germany. And the third speaker is my dear friend, Professor Dr. Nabil Dusoui, Professor of Pediatric University, Cairo University. He's the previous president of the ISHID, which is the Society for the Intersex Anomalies and Hypospadias, International Society. He as well is was previous Secretary General and Treasurer of EPSA and a dear friend. Tonight, the program is what you can see on the screen. We will start by Professor Nabil Dusoui, updates in the clinical staging of neuroblastoma, and then Professor Dr. Nihal Al-Mashad on the treatment based on that staging or on staging, and then Professor Udo Roller will take us through the surgical treatment, and then Nabil will show us clinical cases, direct and problematic, for the final post. For each of these mini lectures or mini speakers parts, there is a moderator who's going to bring up the questions that you ask on the chat area. So whoever has a question, please put it on the chat area, and then he will collect these questions and ask them either at the end of each presentation or at the end of the whole day, pending on the time used by each speaker. I wish you all an interesting night. I wish all our speakers to be having to share with us their great experience. Stopped sharing my screen and we move to Professor Dr. Nabil Dusoui.
Thanks, Ahmed. We've been friends for a long time, and I'm happy to have you as a moderator for this session. Actually, this session is a big topic, and we are trying to collect the cases and collect what is updated in this case. The neurofast cell is very enigmatic in its behavior, and the resultant neuroblastoma are very peculiar tumors that have an enormous spectrum of clinical picture and prognostic factors, and many factors are affecting its late prognosis. Actually, we are, as surgeons, we are present in our mind about the details of surgery and the neglecting the tumor behavior, and which is very, very crucial when we are dealing with, especially with this type of tumor. Actually, this team is struggling tremendously to find the best prognostic factors and the best affecting criteria to reach the best prognosis for the patients, because the high-risk patients are very poor and have a very poor results. I will pass very quickly how these people have in mind and how we are now updated with the last update in the staging of neuroblastoma. In 1971, Ivan has published his classification and his staging based on the extent of the tumor. In 1984, a very, very important article presented by Shimada, and this article continued up till now to be affecting the staging of the neuroblastoma with some modifications. He divided the tumors into favorable and unfavorable, and he introduced the age as one of the factors that affect the prognosis. At that time, researches has been done for the NMEC and the tumor cell ploidy, and it ended by the INSS, or the International Neuroblastoma Staging System, which was based actually on a surgical concept. It is divided according to the degree of the tumor resection and the lymph node involvement and the tumor infiltration. So it is a pure surgical minded classification. At 1997, it was modified, and again, a new 17q gain oncogene was discovered. This all affected the staging. Actually, the International Neuroblastoma Staging System was started in the 80s, and it has been for this long time the only acting staging system affecting the staging of the neuroblastoma. It depends on stage 1, where the tumor is totally resected with lymph node negative, or with either the tumor is partially resected with lymph node negative, or partially or totally resected with lymph node positive. This is stage 2. The stage 3 is crossing the middle line, and the tumor is localized with contralateral lymph node, or the tumor is occupying the midline with bilateral lymph node. Stage 3. The stage 4 is the metastatic or distant stage, and we are left with the stage 4S, where the liver, the bone marrow, or the skin are affected in young boys less than 12 months with negative MI vision. After that, the pathologic criteria introduced themselves to the staging with the International Neuroblastoma Pathological Staging in 1999. This has been modified in 2003, and it depended on classification of according to the some criteria, including this depended on the international neuroblastoma pathology classification is actually a modification of the Shimada classification, but with some introducing some factors, some other factors. It depended on divided this into a ganglioneuroma, mature or immature, or maturating. I'm sorry. The ganglioneuroblastoma intermixed, the ganglioneuroblastoma nodular type, and the neuroblastoma with a different type of differentiation. These are the 4 types, and these types of pathology are going to continue with us in the last staging that we are working with now. At the end, they divided it into the favorable and unfavorable stages. In 2005, it was introduced the 11q aberrations in the chromosome 11 and chromosome 1. And we are ended now with the international risk group factor staging, the INRGSS. This is the stage that the staging system that started at 2005 and continued to 2018, where the American Society approved that this is now the approved staging system, and we are no more using the INSS. This is the International Neuroblastoma Risk Group that started in 2005 by this meeting, and they worked on they collected about 8,000 cases from different parts of the world, and it depended on radiological factors, radiological criteria that are present, with special definition to some of the criteria that show up in the radiology, which are the encasement, the infiltration, and the compression. To be an image-defined risk factor, the vein should be totally occluded, and the artery should be affected by more than 50% of its periphery. This is an image-defined risk factor. If the vein is patent and if the artery is less affected than 50%, this is not an image-defined risk factor. This is to unify the criteria to stage the tumor. Infiltration is, as usual, there is no plane or between this vital structure and margin. As regards the airway and the structure, compression is meant by the trachea and the spinal cord. If the spinal cord is affected by more than 50% of the spinal canal, or the trachea is compressed, this is an image-defined risk factor. If this is not present, it is not an image-defined risk factor, with a special that the air notification that the airway deviation without compression is not a factor positive. All the vessels in the body are when they are in case they are introduced in the criteria of encasement affecting the neck, the thorax or the abdomen. All the big vessels, when they are encased, are included in the criteria, the image criteria, with special announcement for the infiltration of the skull, infiltration of the trachea or the supraclavicular nerves. Also the postchondral junctions and the thorax. Again, the fossa hepatis and the duodenal, the hepatic duodenal ligament and the sciatic notch affection. These are the criteria, together with the encasement of the big vessels, are included in the radiological criteria for staging this tumor. At the end, this staging is divided into 4 categories. The L1, which are localized tumor with no image-defined risk factor. The L2, where the localized tumor with one or more of these factors present. The metastatic one is called the M type, and the metastatic special, which is equivalent to the 4S in the INSS staging system. But the age has been extended to 18 months instead of 12 months. The determination of the risk groups depended on the age, the histology, the grade of the tumor, the NMEC, which is a very important prognostic factor, the 11q aberrations, and the tumor fluid. These are the 4 categories that affect the prognosis in the staging system. The NMEC characterization with the extrachromosomal or chromosomal particles that present. This is a very crucial and very important factor affecting the prognosis of the tumor. These are the proportions of the chromosomal abnormalities and their percentage. The system staging approved that the MIBG has replaced the bone scan to assess the metastatic disease, and the PET is used when the tumor is not avid to the MIBG. The CT scan is used to evaluate the soft tissue disease only, and the bone marrow is to evaluate the bone marrow. I have 1 or 2 slides more. This is the very important figure that show how this staging was built up. We are starting with the trunk of the tumor, and we put on these 4 stages according to whether localized or there are risk factors, image risk factors, or metastatic special. These are the first classification to the 3. After this, when we get a tumor histology or tumor biopsy, the first coming forehead factor is the NMEC. And the tumors are divided whether they are NMEC negative or NMEC positive. This is the main crucial dividing factor after the classification of the image-defined risk factor. Then comes the aberration in the 11q. So now it is going to the molecular concept of prognostic factors that are affecting very much the prognosis of this tumor. So if this tumor is 11q positive or negative, or or NMEC positive or negative, this is the very important factor deciding how this tumor will behave after that. Then comes the age, whether it is below or above 18 months, and the ploidy, as we have said, whether they are hyperploid or diploid. These are affecting the tree. The tree now is completed, and the group have classified this tree into 4 groups: the very low, the low group, the intermediate group, and the high group. These are the prognostic characterization or classification of the prognostic factors of this tumor. And I divided the very low with the letters A, B, and C. And if we see the letter A is going for the maturing ganglioneuroma or ganglioneuroblastoma, and those who are NMEC negative. The NMEC negatives are in green, they have the best prognosis. Then comes the low prognostic group with the D, E, and F, and these are still, most of them are NMEC negative. Still, they are NMEC negative, but they are sometimes they have an 11q aberration positive. Then the group, the intermediate group, and we are left with the high group, which is the very high risk group in this stage. This is the last slide that showed the groups here. The very low, it is the ABC group, the low intermediate, the low risk group, and the intermediate and the high. With their 5-year survival, the best is with the very low prognostic group. Then comes and ended with the high group with the prognosis is very bad. So now we are faced with a tumor with 3 clones: the good, the bad, and the ugly. This is the low, the intermediate, and the high. Thank you. I think we need to change our view to the tumor, considering its behavior and treating it in a different way that we were thinking about. Thank you.
Thank you very much, Nabil. Actually, it was very nice, especially the last 2-3 slides. Can you put the poll, if you have it? That's the first poll. How many cases of neuroblastoma you manage each year? No, 1 to 2, 2 to 5, more than 5. So that's the results of the first poll. 35% of the audience do see 1 to 2 cases. Only 24% are seeing more than 5 cases. And then there are either no in 70% or 2 to 5 cases in 23. So there is around more than 2 cases, around say 50%, or a little bit less. Yeah. Do we have another poll, or that's it? Did you review the last update in neuroblastoma management? No? Yes? Only the surgical update. Straightforward question.
Actually, the American Society has stopped using the INSS staging that we were following for a long time, since 1990, 96 or something like that, till 2018. Then we shifted to the INGRSS.
Can you see it now?
35%
do know the updates,
Okay.
21% know the surgical updates, and 42% did not know any updates about neuroblastoma. We'll
Okay.
move to Dr. Nihal Al-Mashad, the professor of pediatric oncology in Toronto University, about the updates in the management of neuroblastoma in general.
Okay. Thanks a lot, dear professor. Dr. Nabil, it's easier for me after you said a lot about staging. Okay. As we all know, neuroblastoma is the most malignant extracranial solid tumor and is a silent tumor. Also, we know that is arise from sympathetic nervous system. Adrenal gland is the most sites. As regard more than primary sites, we have a lot of symptoms. I restrict some key point in imaging. We must do CT to confirm site size extension and vascular involvement, but MRI in intraspinal extension. As Dr. Nabil said, we must do pre-treatment risk group. We have 3 major risk groups, okay? As regards stage, age, and pathology, appreciation of chromosome mutation. And this is called prognostic factor. In very low risk, problem is with 5-year free survival events. In very low risk, we have mostly 85%, but in high risk, it's less than 50%. Due to heterogeneity of tumor location, grade, and stage, we have treatment modalities ranging from just observation, surgical resection, chemotherapy, radiation therapy, stem cell transplant, and immunotherapy. So we must have principle of therapy. Chemotherapy is important in all staging. We can introduce it as neoadjuvant pre-surgery or adjuvant after surgery. We use it in low risk by low or moderate intensity chemotherapy and intermediate risk also, but in high risk disease, we must do intensive chemotherapy. Cytotoxic drugs used in chemotherapy direct kill cell, cause cell death by block mitosis. If we return to our cell cycle and biology, below we have red DNA, and at the end, at 6 o'clock, we have yellow S phase. Then G2, cell growth and preparation of division, and then mitosis, and then G1. As regards these stages, we have some drugs in chemotherapy, which is cell-specific drugs, and the others cell non-specific drugs. If we turn also to chromosome, the first at the left is normal chromosome and normal cell. After some types of mutation, maybe 1, 2, or 4, we got malignant cell. You know, our DNA in normal, sometimes chromosome, some sort of change occur. Part of material, which is containing DNA, lost, and this is called deletion, which is first one up. Sometimes duplication occur, and this is duplication of gene, or inversion occur, or sometimes translocation. All of these are mutations. Normally, DNA, when divided occur, when division occur, create 2 identical copies. So daughter cell is much more like parent cells. But a mutation is completely different, and then it's mutation. So we must do combined chemotherapy to attack cell in different phases in cell cycle. We use alkylating agents, platinum compound, vinca alkaloid, anthracycline, topoisomerase 1 and 2, and melphalan basilfol. If we return to risk-adapted therapy, we start with low-risk neuroblastoma. It may be just observation. Sometimes observation is a good. We can do surgery. Chemotherapy have a place when low intermediate intensity, if we can't resist, if surgery can't be applied, or if sometimes threatened symptom of spinal cord compression or respiratory bowel compression. Radiation therapy may be used if unresponsive to chemotherapy or unresectable tumor. We go to the second intermediate risk group, which is localized mets with lymph nodes. or bone marrow involvement. We do surgery, and chemotherapy took place here with multi-agents. It's about from 4 to 8 cycles. It depends on favorable biological or not. Also, radiotherapy take place if anything in surgical resection not fit or unresponsive to chemotherapy. Majority of cases are high risk group, and this is the worst prognosis. It's treated by certain scenario by 3 phases. Phase 1 is induction, and then consolidation, and then maintenance. In induction phase, we use chemotherapy, stem cell collection, and surgical resection for the primary tumor. In induction, we must, in high-risk group, use combined agents. It's a must. And then we can go with radiotherapy, depending on the primary site and the bulky disease. It must be attack the cancer cell. Chemotherapy here from 5 to 8 cycles of intensive combined chemotherapy, and the stem cell collected at the end because its patient have little or no residual bone marrow disease at the same time. After we go with induction chemotherapy and stem cell collection and surgical to the primary tumor, we go to the consolidation phase, which is aiming to eliminate remaining minimal disease. Here we use, it's a course in therapy. We use multiple agents, but intensive, like either carboplatin, etoposide, melphalan, or pasalvon-metaman. It's the same, it differs from toxicity profile, not more. And then our duty is radiation therapy. Radiotherapy is using high energy radiation to treat cancer. It kills cell, decrease tumor size, make shrinks, relieve obstruction if spinal or any place, and also decrease pain if compressed nerve. How it's work by damaging DNA. Unfortunately, we have normal cell in the field of radiotherapy. Normal cell have a capability of cell repair in between fractions of radiotherapy. When we have a patient for radiotherapy, he referral from any place, whatever. After referral, we have consultation with us and simulation, treatment planning, treatment process took place. Radiation oncologist must discuss all aspects of disease with parents. Treatment plan is developed, and then our team must be care for this child. Simulation of the patient means patient sit up in treatment position with immobilization device to be sure that planning is perfect. After we create treatment plan, this is our Eclipse system of planning system. Treatment process took place by linear accelerator radiation delivered. Use of radiotherapy in gray, standard amount 21 to primary tumor, but we can go to post up to 36 grade to residual tumor. After radiation therapy finished, we must go in high risk group to maintenance immunotherapy. Maintenance phase means after all other phases, induction and consolidation, it's aiming to treat any residual disease that remain despite all of the 2 phases. If we not go to maintenance therapy, we lost about 50% of patients which will be relapsed later. Maintenance, sure, I must do it to eradicate any minimal residual disease. I use a lot of drugs. I can use retinoids, which is similar to vitamin A. It's help a cell to be mature to normal cell, change cell and regain normal cell. All of this measures it improve survival. We started just after consolidation therapy. The last 10 years, we have a lot of novel therapies like immunotherapy, anti-GD2, vaccines, anti-angiogenic drugs, MIBG, which is iodine, radioactive iodine given intravenous. We have a lot of schools in treatment and maintenance phase, but sure, we must go to retinic acid, anti-GD2, cytokines, and immunotherapy. In Europe, use brentuximab, which is conjugated with isotonic acid. It's IV and oral. Iodine therapy, it's a must. It's taken in the intravenous and carry radiation directly to tumor cell to kill any residual. And as I said, retinoid, vitamin-like drugs, it's taken orally. All of this, unfortunately, about 10% can recurrent. Go to good follow-up, I can manage the patient very well. But sometimes tumor growth due to maturation can differentiate it from progression. So it's a clinical issue and it's a big issue. I must do biopsy. A lot of us can do this, but biopsy is a must. Maybe recurrent or normal cell, and biopsy is the key. Also, uptake. Iodine uptake may be not affect the outcome. Maybe I have a very limited disease or low risk disease with uptake and I go to follow up, not for surgery. But if any neuroblastoma recurrence, we diagnose this as high risk disease and the treatment is same as high risk group disease. I must go again to induction and consolidation and men's disease. So we have just multimodality treatments. Whatever I start with, I finish with, I must go to all these steps. I must follow up the patient very well. I think all of us have a lot of farmers in his centers. We must discuss with the patient and educate the patient how to deal with this child, okay? We have multi-team. We must have a good relationship as we do now. We must discuss all of this with us. We have a lot of international papers in these aspects, Egyptian, and that is all. I just will go to one video. Tamam?
Thank you so much, Dr. Nihal. Actually,
it's okay.
I tried to make a very complicated issue for pediatric surgeons, which is the medical treatment of neuroblastoma. You tried to make it simple. So thank you so very much for your effort.
I try also.
An excellent lecture. Thank you so much.
Thanks a lot.
And I think now we are moving to Udo Roller, the Secretary General and the Treasurer of WOFAPS, and he is the Chief of Pediatric Surgery and Pediatric Urology in Frankfurt, in Gotha Frankfurt Am Hospital in Germany. Udo, you can now unshare, please, your screen, Professor Nihal, and Udo, if you can share your screen.
Can you see that?
Yes.
Yes.
Perfect.
Yeah,
Perfect.
it's very clear.
So first of all, I really would like to thank the two co-speakers, Dr. Nihal and Dr. Nabil, for giving me this perfect introduction for the surgical strategies in neuroblastoma. Of course, I'd like to thank my dear friend Sami Shihata to invite me, and my friend Professor Saki and Professor Sharif Shihata to share this session, which I'm impressed because I've seen there are more than 170 people which are watching us. I was asked to talk a bit about surgical strategies in neuroblastoma. So it's a pleasure for me. As already said, I'm a pediatric surgeon from Germany in Frankfurt. We heard a lot about neuroblastoma, especially Dr. Nihal and Dr. Nabil almost said everything. The only thing that almost strikes us is that we deal with a tumor which has a really heterogeneous behavior. And this might be explained by this beautiful slide, which I'd like to share with you, which shows the regular sympathetic neuron differentiation in difference to neuroblastoma development. So as you can see here, the precursor cells from the sympathico-adrenal system, they might develop to a neuroblastoma. And then we have this two clinical scenario that they either go into regression, which we have seen especially in the young kids and the kids who don't have expression of NMYC and don't have the amplification of P1. And the other population might go into a
Udo, if you can get closer to the computer and
yes,
raise your voice a little bit.
Okay, I try to get this upwards. Is it better now?
Yes.
Yeah,
okay.
Yeah, it's better.
I'm sorry, so I speak louder. I'm alone at home, so I can do that. This is the INSS strategy, which has already been explained by Dr. Nabil, and this is the German system. So we have a univocal protocol which every German child has to undergo. Every German child diagnosed with a neuroblastoma has to get into a standardized protocol. And of course, we use this classification. So, this is the one which the surgeons most like, because this is the stage 1 to stage 4S, which is based on the surgical behavior, if you can express like this, of the tumor. And at the end of the talk, I will tell you our own experience on the stage 4 neuroblastoma, which is any primary tumor with a disseminated disease to lymph nodes, bone marrow, and other things, so metastatic disease. We have already learned from the two distinguished speakers before me about the International Neuroblastoma Risk Staging System, which comes to the end to stratify into L1, L2, M, and MS tumors. The same has, of course, adapted, sorry, this is the wrong direction. The same has, of course, adapted by the German system, which is called the Neuroblastoma Protocol 204, which is now will be exchanged to 216, but we still talk about the same tumor staging system, L1, L2, M, and MS. And this is what we just heard about. So in accordance to the ERG stage, age, histological category, grade of differentiation, MYC-N amplification, 11q aberration, plurality, we can come up like in the right column, and we can stratify the pre-treatment risk of our patients. And again, we have heard about this today already, about the image-defined risk factors, which play a crucial role for us as surgeons. They're very well defined, so they are distributed between the neck, cervicothoracic junction, thorax, thoracoabdominal, abdominal, pelvis, and then a special attention is placed to the interspinal tumor extension, which usually requires a multidisciplinary approach at surgery. To make the things easier, which is always good for surgeons, I like especially this one. So the basic message of the ENRG classification is that we have high, intermediate, and low to very low risk tumors. The aggressive neuroblastomas are the ones usually with the segmental chromosomal aberrations, and the benign neuroblastomas are usually those with whole chromosome chains and no segmental aberrations. This as I said, makes the things maybe easier for us if we have to consent the parents and the families about the cause of the disease. And again, the risk factors have, of course, it's very valid to talk about prognostic categories, and this is not new to you. If we talk about low risk factors, low risk tumors, which is here on the left, they have a survival rate of almost 100%. Intermediate risk, in our days now with the multimodal treatment, as just real nicely explained by Dr. Nihal, they have a survival rate until 95%, but then we go to the high risk, and the high risk tumors still have a mortality rate between 40 to 50%. And of course, a special one, the tumor stage 4S, as we all know, has a very nice prognosis. This is some information from our protocol, which has just been explained from Dr. Nihal. And you can see the low risk groups, observation group, they will go, in some instances, they will only go for observation. If they have a localized progression, then they will go for several chemotherapy, but they usually don't go for a surgery. It's the same for the progression to stage 4, which usually doesn't require surgery. In the opposite, the medium risk groups, which are usually the stages, surgical stages 3 and maybe 2 if there is a 1P operation, they have at least 2 situations where they have to face surgery. It's usually at the early beginning to have a biopsy, to have a proper histology, and it is somewhere between the N6 blocks and the second N6 blocks where we have to discuss with our pediatric oncologists if we do surgery at this time of the treatment. And the same applies for the high-risk groups, which will be stratified in these 2 arms. And again, biopsy at the beginning and primary surgery and during the course of chemotherapy, always in accordance to the protocols which are discussed by the tumors. And the special approach now is to have in the high-risk group at this stage stem cell therapy, transplantation therapy, which is a new aspect of treatment for several years now. So surgical aspects in neuroblastoma, as I mentioned already, initial biopsy. This could be done percutaneously, but it's not always required because always adequate, because we need a certain amount of tissue, because we not only have to do it for the primary diagnosis, we only have to do it for the molecular biological diagnosis, and we have, at least we do this now in Germany, we have to keep it frozen for later research. So it can be done by a true cut, or usually we offer our help to do open, limited open or laparoscopic surgical biopsy for the first approach for the diagnosis. Surgical planning for resection of the primary tumor is of course always related to the image-derived risk factors, which play a crucial role in the approach, in the discussion, and in the evaluation of possible complication, as well as in the evaluation of a possible R0 resection. The resection of the primary tumor is usually done to achieve local control, so to really resect it, and which is a basic rule in neuroblastoma surgery to do not mutilate. Resection of metastasis or secondary disease is very rare and will be indicated even individually. The surgical therapy of the primary tumor is very clear. So usually it's open surgery, might be laparoscopic surgery in individual cases. We could discuss this later. The usual incisions for abdominal tumors is midline or transverse, thorax, posterior, and underlateral incision, and the cervical approaches individually. In accordance to the image-derived risk factors, we have to be sure that we have either our own abilities in vascular surgery, or we do have to have colleagues together with us. And this also applies for neurosurgery if the tumors are invading the spinal column. And again, no mutilation. which we can achieve, especially in stage 1 to stage 3, if it comes to the surgical staging, is a complete resection, including lymph node resection. And there is a very clear positive influence on the prognosis after this surgery. A stage 4 could be tried for a complete resection, but the influence of the prognosis is not already completely clear right now. And I will show you very soon our own results on that. Complications, which we have to talk about in neuroblastoma surgery, they can be up to 20% of the cases. This is results from the big German protocol study, which includes surgery from almost 20 years, several thousand of patients. And I'm quite surprised about the low rates of complications, because I have to say I experienced a little bit more of that. Infections 4%, pulmonary problems 3%, ileus 3%, renal injuries 2.3%, bleeding, and wound infection. Just some examples. You can see a typical stage 1. All of you who are surgical, surgeon know that. And the stage 1, you can usually easily resect without any damage, and as our zero resection, which is most favorable for the outcome of the patient. Here we have an example from a neck neuroblastoma, which has been resected by incision left cervical. And you can see it usually was behind the big vessels, and the resection was quite uneventful. This is a typical stage 1, a thoracal neuroblastoma. Unfortunately, I couldn't find intraoperative images, but I can tell you that this was also a straightforward resection of our zero kind. This is a typical stage 3 neuroblastoma in the abdomen. Here the tumor has been, just for you, for the photograph, has been put back after surgery, and here the tumor is behind all the big vessels. And this is the one which is the most complicated. If we have extended tumor, usually arising from the paraganglions in the abdomen, which is extending from the left upper abdomen down to the pelvic. This is a typical resection result. You can see it again. Here you can see it's unfortunately written in German. This is the left adrenoid gland. This is para-aortal, and this is iliacal. So this is the whole tumor. It's the primary tumor, and of course metastasis to the lymph nodes. This is the protocol, or this is like a report. I'm sorry, it's in German, which we have to fill out after any resection for neuroblastoma, and which has to be sent to the neuroblastoma center, which is actually located now in Cologne. So you have to state, is it a primary tumor? Is it a metastatic disease? Is it radical surgery, or it's only an excision? Which is the stage, infiltration above the midline, lymph nodes, and you have to state which lymph nodes you have resected. Intraoperative complications as none, nephrectomy, bleeding, infection, ileus, and then histology, and of course the remission status before and after surgery. And we believe this is a very, very valid measure to really look for the surgical report, for surgical success. But all of you know that this is not really independent and unbiased. Any surgeon maybe tends to report a little bit better than it actually happened. The last part of my short talk should be about impact of surgery on prognosis in stage 4 neuroblastoma. There are several studies already published. Most of them are not really recent, first half of the 2000s. And that's been stated there as a slight benefit of patients after gross resection in regards to local control and overall survival. The problem is that you really have to define what you are talking about. If this is a complete resection, so 100% of the tumor is removed. If it's a gross total resection, so if it's up to 95% and not less than 80%, or if only a biopsy, or if it's surgery. And these are some of the papers. I can send the talk to you if you want. There's some examples, like from 2012, from our colleagues in Holland. They have looked for a review of several studies, and they found survival benefits in patients which have a complete resection, but also they found the same survival benefits in patients which have a gross total resection. But only 4 studies compared really complete resection versus gross total resection, and only 2 showed a better outcome for complete resection. This is the German results from 2013. This is the Neuroblastoma 97 study, which is the one before the 2004, which is ongoing now. And they included patients older than 18 months. They had data from 278 patients. A little bit more than half had complete resection, 30% incomplete, and 13% only biopsy. And this study concluded that there is no impact of complete resection on overall survival, event-free survival, and local progression-free survival. Again, another study from 2009, which is not really a surprise to us, that patients with neuroblastoma stage 4, which have also a MYC-N amplification for more than 10 copies, they have a poor survival despite intensified treatment. And the last paper I would like to tell you about is from 2017 from colleagues from Japan. And they reported that a gross total resection is possible and effective in delayed local treatment of neuroblastoma stage 4, and combined with radiation, it has a benefit for the prognosis. We have looked at our patients and have published this about 2 years ago. This was a single center study retrospective only on stage 4 neuroblastoma from quite a long time, which is 22 years, but still we were able to identify 40 patients, typical age group, about 3 years. And we compared them in the groups with biopsy only, or no resection, and subtotal resection, which means resection up to from 50 to 90%, to another group, which is radical surgical group, near complete resection, more than 90%, and complete resection. Retrospective chart review, so it has its drawbacks and its bias. And this is the patient groups. You can see on the left, there's a radical group, 9%. On the right, there's a non-radical group, 11%. There's no differences in the age, no differences in the treatment protocols, no differences in the primary tumors. Of course, there is a difference in metastatic disease, because no, it's not. I'm sorry, it's not because they all neuroblastoma of stage 4. And the same, there's no difference in on events, on relapse, but there is a clear difference on death and complications. And this is the first Kaplan-Meier curve we'd like to show you. It's on the overall survival. So the overall survival in years, as you can see here, this is the group which had at least more than 90% resection. They have a significant better overall survival than the group which had only incomplete resection or biopsy. And you can see the same here in the multivariate analysis. It's a p-value of 0.002. And the same applies for the event-free survival in years. So again, the group with complete or almost complete resection compared to the group with incomplete resection or a biopsy has clear benefit. It's a significant longer event-free survival. If you look at complications, so there is no difference in looking at the overall survival and the event-free survival of the two groups. So they have about the same amount of complications. There is a slight, but not a significant clear difference in stem cell therapy, which is not a surprise for us as well. So the patients who underwent stem cell therapy, which was of course the later patients, have a slight benefit in survival, but not in event-free survival. So that's the same almost. And radiation does not provide any benefit either in the event-free survival and as in the overall survival. And the time of treatment, as you know, we have included patients from 2 different time frames, might have a trend that the patients after 2000 have a benefit in survival, but this is not significant. And the same applies for the event-free survival. The complications we have seen, that's why I was a little bit suspicious of the overall complications I stated at the beginning of my talk, are quite significant. So we lost 7 kidneys, of course, due to damage of the renal artery. We had kidney insufficiency of 4, bowel necrosis in 2, atypic liver resection in 4, resection of gallbladder, ileus 4%, and we also had sequelae of neurological complications due to nerve damages. And all the others which are related maybe to the disease itself. So thank you for your attendance. I would like to summarize the overall prognosis and event-free survival are significantly better after radical surgery in neuroblastoma stage 4 in our series. Radical tumor resection, which means more than 90%, is an independent risk factor for neuroblastoma stage 4. Surgery-related complications are frequent in our series, more than 30%, and severe, but usually without influence on survival. The limitations of our study are very clear. It's a small sample size, it's a retrospective study, and it colored two different treatment protocols. Thank you very much.
Thank you very much, Professor Voller. Actually, in this topic that we don't see lots of patients, I'd like to thank you very much for sharing your experience and highlighting the value of surgery at different stages, whether in staging, biopsy, or definitively. Thank you so much. We'll move to Professor Dr. Nabil Dessouky in the last section of tonight's presentation, so that we can move after that to the questioning part. And Professor Nabil will show us difficult and problematic cases. Professor Nabil, please share your screen.
Okay, this female child was 1.8 year with presenting with a huge abdominal mass and no other symptoms. When we did a CT scan, we can see a huge mass here, encasing the aorta, the renals, the iliacs, and the superior and maybe the cilia. We did, as usual, the bilateral bone marrow aspirate according to the protocol, which proved to be positive for neuroblastoma. The PET scan was free from any metastasis. Only the MIBJ was taken. The dye was taken by the tumor. And according to the protocol, we started a chemotherapy for after the 3rd cycle. You can see that the tumor has shrunken very much in size. The vessels started to be relieved from the pressure, and the kidney also. The kidney was not are now free. And we, after the 3rd cycle, we subjected the patient to resection of the tumor. It was an easy operation. The mass was smaller than in size, and the tissue was not that fibrous and adherent to the adventitia of the vessel. This is the first case. The second case is a similar case of a female child, 4-year-old, with a right abdominal mass and no other symptoms. Again, the bone marrow aspirate is positive for tumor cells. We did an ultrasonography and then a CT scan, and we can see that the celiac, the aorta, the iliacs, and even the renal were encased by the tumor. The mass was measuring 10 by 9 centimeters, and the tumor was inseparable from the kidney. Here we can see the aorta is elevated out from the back of the spine, and the superior mesenteric and the celiac are affected, and the mass is very huge. We cannot go with surgery for this patient. The iliacs are here, are encased. We did a PET scan for him, which proved to be negative, and then we subjected him to chemotherapy. Post chemotherapy with the 1st cycle, the mass started to shrink out, and the kidney started to be separable from the tumor. the mass regressed here, and the aorta started to be relieved from the pressure. The aorta returned back to the spine, to his normal spine, and the mass nearly got smaller. This is a classic case of straightforward management of a case of a neuroblastoma. The mass was 10 by 7. Now it is 5 by 3, which is we went in surgery, which was an easy operation. Here we can see that the aorta here is free, the renal hilum is free, and the mass is not encasing any vessel, major vessel, I mean. We will move to the non-straightforward or non-direct cases. This is a patient that presented at the age of 10 years with bowel and urinary dysfunctions, and she has a mass in the lower back and perineum. Occasionally, she has some chest infection. Otherwise, she was normal. When we did a CT scan, we can see a huge pelvic mass arising from the pelvis, pushing the bladder and eroding the sacrum and going into the spinal cord. This is a large mass filling the lumbosacral spinal canal, closely related to the conus medullaris, and the sacrum was destroyed, and the soft tissue mass was extending from the third lumbar to down to the sacrum. The mass was pushing the bladder anteriorly and pushing the rectum to the left side, and we can see in the CT scan there is nodules in the right lung. Still the origin could not be detected. So I'm raising the questions now. What is the management of these cases from the panelists and from the attendees? This is just to put some spices into the discussion. This is another case, a female child, 3 months old, presented just with jaundice. The total bilirubin was 8.8 and the direct was 7.9, and no abdominal mass could be felt in the child. Otherwise, she was normal. When we did an ultrasonography, the gallbladder was distended by 1.5 centimeter, and the common bile duct was dilated in 6.5 at the porta hepatis, and a solid mass was present at the porta hepatis, measuring 3 centimeter by 3.5 with a volume of 21 centimeter. We did a CT scan, and we can see the mass occupying the porta hepatis, compressing the common bile duct, and here at the hilum of the porta hepatis. Operatively, we subjected the patient to operation because the child was the bilirubin was rising, and we can see that the common bile duct and the gallbladder are distended here with a tumor occupying the porta hepatis, compressing the common bile duct above the duodenal and retroduodenal, just at the pancreas, just above the pancreas. This is the tumor engulfing the common bile duct, and this is the remnant opening into the duodenum with the pancreas here. The management was really difficult, and we decided to remove the tumor with the common bile duct, and here the tumor is removed with the celiac trunk here with the hepatic, and the vessels are skeletonized. The tumor was removed, and we did a biliary diversion for the common hepatic duct at the porta hepatis. At that time, we didn't know how to manage, but this was the solution to resolve the condition. Maybe it is for discussion with Professor Nihal and Udo and all the attendees. Could have given a preoperative chemotherapy or not. Still, it is for discussion. This is another case also, but 2 years old, presented again with jaundice with a total bilirubin of 6, mainly of the direct type, but here a mass is felt in the right hypochondrium. On ultrasonography, the mass was visualized, and we did an operative cholangiogram that proved that the gallbladder and the hepatic ducts are dilated with no common hepatic duct, common bile duct seen in the operative cholangiogram. Here we can see the gallbladder is distended with the tumor compressing on the common bile duct. Sorry. This is another case, a 6-year-old child, 3 years old child, male, that presented only with abnormal movement of the eyes and of the body, of the limbs. Involuntary movement of the eyes and jerky movement of the limbs. In a picture of ataxia like condition. Here we can see the eyes going in all directions, which is was the only symptom that he presented with. When we did a CT, it showed a right adrenal mass with calcification here, there. And this patient was subjected to surgery. We removed the tumor, and unfortunately, the patient didn't recover totally from this ataxia. And as we are going to see, it's a case of opsoclonus myoclonus syndrome, or the dancing eye, dancing feet syndrome, or the OMS, or when it has an ataxia. It is called OMAS disease, which is an autoimmune occurring with neuroblastoma in children, and it is due to the beta cells, the CD20, attacking the nervous system, especially the cerebellum, and causing this manifestation. The eye movement is in all directions, involuntary, with jerky movement of the limbs and maybe ataxia. And this is treated with corticosteroid and immunosuppressive treatment. The next case is a child that has been a well-known case of neuroblastoma, a female child, 6 years old, that did resection of the neuroblastoma before and received full cycles of chemotherapy, and she was put on follow-up. But 1.5 years later, she developed recurrence of her disease. A mass here was seen, measuring 2.5 by 1.5, and there is a cystic mass, hypodense area in the mass. This is put for discussion. Is it better to remove this mass or not? But at that time we removed it. Maybe this the mass could be benefited from any other modalities of treatment, but the tumor, when resected and subjected to histopathology, proved that it is formed of maturating ganglion cells with marked tumor necrosis. So it is a maturing form of neuroblastoma or ganglion neuroblastoma, and it is put for you for discussion. This is another case scenario. This is for what we call the MS or M special, or the previously called for S stage. A male child, 5 months old, with 2 small bluish masses. This was the only presenting symptoms. a mass in the anterior abdomen and above the eyebrow. And when we did an ultrasonography, there is a huge hepatomegaly with multiple well-defined focal masses, heterogeneous in consistency with no other abnormalities. And and a mass here in the adrenal. The liver was stunted with multiple focal lesions, and it was 17 centimeters in span with an adrenal mass 5 by 4 by 3. Again, with no metastasis here. The mass was 5 centimeters. We were afraid this is the cut-off age to follow up the cases of 4S or MS cases, and we decided to remove it because fearing of turning into an aggressive form of neuroblastoma. This is all again for discussion. For management of these cases that are borderline, they are not 3 centimeters or less, they are 5 centimeters in size. This is another neonate, 6 days old, with abdominal enlargement, with a palpable intra-abdominal mass in the left loin, with no hepatomegaly at that time and no palpable skin lesions. It presented with only a mass. The mass was occupying the heterogeneous 5.7 by 5.7 centimeter in diameter, with no hepatomegaly at that time. There is a very small cystic mass in the liver that was followed up, but after the patient was put on under observation, but we noticed that the mass increased in size and reached 7.7 by 6 by 6, and it was inseparable from the kidney. And at that time, no hepatomegaly was present, and still the cyst is present in segment 8. We resected the tumor because the tumor was increasing in size. It reached 7 centimeters in diameter. So we resected the tumor. But after 2 weeks of post-operatively, the full-blown picture of the 4S or the MS stage appeared in the liver with multiple focal lesions in the liver after resection of the tumor. This is again for your kind discussion. Now,
please, Dr. Nabil, after this one, we want to start discussion.
Do we put this patient under follow-up, or we give him a chemotherapy? The last case, I think, is a case of sympathetic chain ganglioneuroma, neuroblastoma actually. This is a child that presented with a loin mass 6 by 4 with displacement of the kidney and no back pressure. Here you can see the mass occupying here the adrenal gland, compressing the kidney. The mass was removed and totally, and the kidney was spared. Thank you very much. I'm sorry, this is just to put some questions on how we deal with this case. Thank you.
Thank you very much, Nabil. I'd like to thank Nabil, Udo Rolo, and Dr. Nihal Mashad for their presentations today.
First question is about what is your opinion about upfront surgery and biopsy and preoperative chemotherapy?
For what? For high risk or intermediate risk?
This is the question. What do you think about upfront surgery or biopsy and chemotherapy?
Okay, I go to surgery first if it's available, it's visible. It's okay. Sometimes it's, as I see in CT or MRI, it's closed major vessels. Sometimes we get after surgery unresected parts, so we prefer to go to induction chemotherapy. If it's okay for surgeon and can give us R0, it's okay.
Another question is, what is your opinion about radiotherapy for spinal cord compression?
The radiotherapy mainly used in spinal cord compression, but we sometimes give about 2 cycles of chemotherapy first, interval 21 days, to shrink the tumor, and then radiotherapy 21 gray, and it's okay. After that, sometimes it's completely disappear.
Could neuroblastoma treatment affect child's ability to become pregnant and have children in the future? If so, should family talk with a fertility specialist before cancer treatment begins?
Okay. If we talk about this, I see about in the last 10 years, about 5 cases. It didn't affect anymore. But sometimes it's, as I said to you, we need patient education and parent education because psychological aspects, not organic. Okay, but I don't think so.
Okay.
May I comment on this, please?
Yes,
okay.
yes.
Okay, sure.
In the cases where the patients have to undergo stem cell transplantation, which is especially in the high-risk group, now a very valid treatment option, they actually really go into the danger that they will be infertile after that. And we offer a program not only for those patients, but for other patients which have to go severe chemotherapy, which may be in danger for the fertility. We offer a program now for both boys and girls to go for a fertility protection. So we take either their parts of the ovaries or parts of the testicles and preserve them for further measures, which are very valid already in girls, but not in boys. But we have offered this, we start to offer this to our patients, especially if they undergo stem cell transplantation.
Stem cell, okay.
Okay, thank you. Dr. Nihal, how do you
I have just one comment for this. If you go only for chemotherapy or radiotherapy, it's not affect anything, okay? For this issue, okay? Infertility.
Okay, how do you stratify the risk grouping in setups where cytogenetic analysis is not available?
As different questions, because it's a
You can't.
I can't, of course.
You cannot.
You can go to biostaging is 20 years ago, by age less than and more than 18 months. Staging, very simple staging, but it's difficult.
You should have.
You must do all of this. We must search for information.
If you are serving these cases, you should have this or refer to another center. What about the effect of use of anti-GD2 monoclonal antibody to prevent relapse in patients with neuroblastoma in immunotherapeutic approach?
Okay, as we said in presentation, any recurrence, must be treated like high risk, okay? We go the same induction and consolidation and maintenance. So immunotherapy must take place.
Okay, thank you, Dr. Nihal. Dr. Role. Dr. Role, what is your COG protocol based on INRGS?
So we do have a formalized tumor board, which we have every week. And there we always discuss all the patients, not only neuroblastoma patients. And if we have a patient which is due for surgery in neuroblastoma, so then we talk to the radiologists and the pediatric oncologists to find an individual approach for these patients. So we don't have like a formalized protocol, so we all do this in individual case discussions.
Okay. What's your approach for spinal cord compression? Is there a cutoff point when you go for urgent surgical decompression? And is there any role for decompression after 4 weeks, or is the cord relatively already irreversibly damaged?
It's all based on clinical symptoms, and it's of course not the decision of an individual pediatric surgeon. It's a decision again in the tumor board together with our neurosurgeons, because if really tumor extends into the spinal cord and compresses the spinal cord. This is, at least in our setting, not a surgery to be done by us. It's to be done by the neurosurgeons.
Well, what's your approach for cervicomediastinal neuroblastomas?
Yeah,
Incision, how to plan the incision? Yeah.
The question was if what we do for a bilateral cervical tumor. Again, if you are able to reach the tumor which is bilateral found by one incision, it's fine. But usually, the principle is that you have to get a good exposure. You have to get a good exposure to really resect the tumor completely and avoid any damage to any surrounding structures. So in any case of doubt, we would go for bilateral tumor with bilateral incisions.
Oh, all right. Is there any difference about therapeutic protocol between thoracic and suprarenal neuroblastomas?
No. As I said, as I wrote in the chat room, our patients have to undergo a very strict protocol. So they all get a biopsy as to really define the source, the kind of tumor, to define the risk, and put them into the protocol groups. And then if needed, they undergo all of them, at least 3 to 4 cycles of chemotherapy. And then we discuss about surgery, and this is the same protocol, regardless if the tumor is above or below the diaphragm.
Right. Your operation pictures are perfect. How do you apply for bleeding control? Do you use vessel energy sealing devices or clips or?
So we use the usual thing. We use this electric scissors and as I wrote to the chat room as well, and either we do clips for the small vessels and ligation for the bigger ones. And I said already, it's really up to the surgeon's preference, and all of you are experienced surgeons. And I think there's not a really strict protocol. You want to get bleeding control, and you do this on the way you are used to do, and which is the most, which is the best for you and for the, of course, and for the patient.
Another question in the same issue is, what's your opinion about devices using water with high pressure? Do you think they are useful in dissection for tumors?
To be honest, I don't have experience with that. We use this. Sometimes we use this harmonic scalpel, which you can use either laparoscopically or open. And we use especially this electric scissors. I don't know the right name in English, and that's it.
What's your management of chyluria as a complication following surgery of abdominal neuroblastoma?
Sit and wait. Watch and wait.
I think so. Do you find the intraoperative use of color Doppler ultrasound of benefit in identifying vascular structures encased by tumor tissues?
Yes, yeah, definitely. Most definitely, we have a special ultrasound device which is especially useful for Doppler ultrasound to identify vessels. If there's any doubt, we use that one to get more information. Yeah.
But you said at your talk that there is no mutilation if you can't completely excise the tumor without injuring major vessels. You can leave residue behind.
Mm-hmm.
What we all try to do, and which is the main approach, no mutilation just means that you should not try to get a full resection even with healthy margins. If you put a valid important organ into danger, you should not resect R0 if you have to sacrifice a kidney, or if you have to sacrifice a bowel. Or bowel vessels. So either you can leave a small port behind, so it doesn't basically make a big difference if you do a R1 resection and you respect all the vital structures. This is just like a basic approach. Of course, we have, as I said, we have a lot of complications because we tried to do a complete resection, and there we have most of the problems we did have with the renal vessels. Even after surgery, 1, 2, 3 days later, you can see that they have gone to renal failure, and obviously due to you have a comprised and they have a problem of the renal artery.
Some questions. they say that neuroblastoma is not a nephrogenic tumor, so they are asking about the nephrectomies in your series.
We never do a nephrectomy on purpose.
Yes,
we have done
vascular injury.
Yes, we have done some late nephrectomies if we had a severe vascular injury and the kidney was atrophic, but then usually we leave them, and we don't. That's what I meant with the no mutilation. So we would not go for nephrectomy, even if the renal hilus is severely encased. We would try to resect as much as possible, but we try, of course, to prevent the kidney. So nephrectomies in our series is all complications.
Yes. Thank you, Dr. Roli. Now, Dr. Ahmed Gafar and Professor Nabil Dessouky.
For the cases presented by Dr. Nabil, Udo, and Dr. Nihal, do you have comments on the interesting cases presented by Dr. Nabil on the wide spectrum of cases? Obstructive
Especially the
jaundice,
neonatal one.
Yeah, neonatal case. Oh, do you have a comment?
Sorry, can you repeat the question, please?
Yes, I'm talking about the cases presented by Dr. Nabil in the last section, the interesting cases like atypical presentations with obstructive jaundice, the neonatal case less than 3 months of age. Would you like to comment on these interesting cases? He has a very nice series.
The problem is for me, first of all, I have not any experience in this, especially not in the cases with little babies and jaundice, because basically, if you have a neuroblastoma in this age, this will be basically the age group where you can just watch and wait after you know what the histology of the tumor is. But obviously, if you have a complication like obstructive jaundice, then you need to go for surgery. And I think especially the case with this tumor which obstructed the main bile duct was a really clever and wise approach to resect the tumor, resect the common bile duct, and make a biliodigestive anastomosis. And obviously, if the child, if tumor completes the story, so the child should be cured. Some of the others of the first ones with the really big tumors in the small pelvis, which are obstructing the bladder and the rectum, is extremely difficult. All of us know if you go for a resection, you might end up with a complete disaster, so destroying continence, destroying actually the outlet structures. So the child might end up with a cystostomy and a colostomy. So this will be again for us an approach for alternative treatment like MIBG or antibody treatment or radiation therapy. But again, this is so rare that this will be based on a very big discussion in our tumor board.
I think there's a problem in communication with Professor Nabil. So if we don't have any other further comments for Uda or Dr. Nihal,
we can close the session. Yes.
Close the session.
If any comments from Dr. Udo or Dr. Nihal or Dr. Ahmed Gafar, you can pass some of the questions to the Dr. Udo and Dr. Nihal.
The question about non-MIBG avid metastasis. How we can suspect that cases?
For me?
Yes.
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 Okay. Sometimes, you know, PET-CT or MIBG, it's not conclusive, okay? We sometimes have false positive or negative. So if we have something like that, biopsy is a must, okay? Sometimes we wait and then repeat PET-CT after 1 month. It's a must.
Okay. Related to the same question, if we do MIBG, is there no need for bone marrow biopsy, or we still do bone marrow biopsy?
No, individualized, not all cases.
Not all cases.
Yes.
Okay, another question, the same as asked by Dr. Akram, do we need to do a pre-chemotherapy biopsy?
What? Pre-chemotherapy biopsy?
Biopsy before chemotherapy?
Of course.
How
can I treat
a biopsy? Biopsy pre-chemotherapy, before chemotherapy?
Biopsy first, and then we decide the decision made later. We must do biopsy first, of course.
Thank you.
Okay, I think I'd like to thank all the speakers, all the participants, and the organizers, and thank you all, and have a nice night until we meet next week, inshallah. Assalamu alaikum.
Alaikum assalam.
Thank you so much.
Thank you all. Thank you all. Thank you for all speakers. Thank you.